Hello everyone, I'm back from Chicago ASCO 2025. It was my great pleasure to be there. I want to thank again the organizers to invite me to open this session about real-world immunotherapy, bridging the gap between trials and treatment. I really encourage you to see, if you can, the session on the ASCO website. There is a link here on the slide. And just to briefly introduce, as you can see from left to right, Kristen, Ronnie Spencer, and Elena Elez were the moderators. Myself, Vanita Norona presented very interesting data about dosing in immune checkpoint blockade. Francis Levy presented data about chronotherapy. Jordi Ramon from Gustav Rossi put in perspective of the data. Then Muntazer Azi would present data on organ transplant recipient, and Elad Sharon put that in perspective. So I really encourage you to see the full session, the full data. Also, the Q&A session was really engaging. But because I know not everyone has access to the online ASCO session, I will record again my session today. And so let's get into it. Optimizing delivery of checkpoint blockade in the real world. So to summarize, there are three questions. First, why we should optimize delivery of checkpoint blockade in the real world. And this is mainly because of two things. First, we have a difference between efficacy, what is seen in trials, and effectiveness, what is seen in the real world. This is the famous efficacy-effectiveness gap, but it can be other gaps, and we'll go through them. The other thing is, after first approval, you have still a lot of remaining questions. What is the optimal dosing of therapy, duration, timing, subpopulation, and many others. Now it comes to how we can answer this question. I will be focusing mainly on real-world data, which is generating real-world evidence, and we'll go through the methods to get those evidence, and what is called pragmatic trials. So pragmatic trials is very close to daily practice. And last, we have challenges. For real-world evidence, the main challenges I see is really when you try to compare strategies, and this is mainly due to selection bias. And for pragmatic trials, they are very challenging to run and to fund. Let's first focus on the efficacy-effectiveness gap. Again, efficacy is what you will get in a trial, and effectiveness in the real world. And why there would be a difference between those? In this very nice work from Marco Donia and colleagues, they assess whether their patient would have been eligible to a trial, and they saw that 45% of them only would have been eligible for a trial. They also elegantly show that the survival of those was much longer as compared to those that would not have been eligible for a trial. So this is really the key point about the efficacy-effectiveness trial, is that real-world patients often do not resemble those included in trials. Beyond melanoma, but still for checkpoint blockade, this was a very interesting study, pooled analysis of advanced melanoma, renal, and lung, and in this nice study, they show similar results. But if we go beyond efficacy, because very often, and this is from Brooke Wilson and colleagues' work, when we talk about the efficacy-effectiveness gap, we often talk about survival outcomes, but there are other gaps: cost, time toxicity, quality of life, and treatment toxicity. Here, I will focus on treatment toxicity with the question, is there a toxicity gap? Intuitively, you would say, yes, patients who are frailer, older, and have more comorbidities would tend to suffer more from side effects. But in reality, it's very difficult to capture. In trials, capturing adverse events is pretty straightforward. I hear you, it's not always the case, a lot of paperwork, it's not 100% accurate, but in the real world, it can become very messy. So it's not always clear. And so the question is how we can really benchmark this toxicity gap. And I think the answer is with very well-curated, prospectively collected data. Let's take an example. Adjuvant anti-PD-1 therapy, stage 3, resected melanoma. And here we have toxicity data from the Keynote 054 trial. Again, I will use the Danish data, and congratulations to the Danish group. Very well created data, and as you can see, there's doubling rates of patients who discontinue therapy due to toxicity. So this is really what is called the toxicity gap. Why we should benchmark those gaps? Because it can really inform your shared decision. You really have a continuum between what is seen in clinical trial and what is seen in the real world for efficacy effectiveness gap, but also for other gaps. And the question you should have is, where is my patient? And this can help you to inform shared decision. The other important question is, after a first approval, you still have a lot of remaining questions. In this recent work from Gauthier Bush and colleagues, I really encourage you to read this work. They are really showing those many questions. Question about dosing, Vanita Norona will present data. Question about timing, Francis Levy will touch upon that. Question about subpopulation, and Muntazer Azioud will present work on that, but many other questions. And now I will focus on how we can answer those questions. I will mainly focusing on real-world evidence and clinical trials, mainly pragmatic trials. So now let's tackle about the how we can answer those questions. The first thing is real-world data. Real-world data definition is basically data coming from outside clinical trials. And based on real-world data, you will generate real-world evidence through some methods. Now let's go through some of these methods. The first thing is very basic, descriptive, observational studies that can be very powerful. Let's say you want to assess the risk of autoimmune disease flare during anti-PD-1 therapy. This is a pretty common question in practice, and those populations are often excluded from trials. But based on observational studies, for instance, in this work, you can see that patients with polyarthria rheumatica had more than 70% of change risk of flare. So this is already informing your clinical practice in some populations. Now let's see other methods. Propensity score matching. Now you will try to compare treatment strategy. So you have a cohort of interest and you want to compare with some external control. You will apply a score. I won't go into the details, but the score basically tries to match patients. One limitation with this method is when you don't have a match, you will exclude some patients. So this is a key limitation. How to overcome this? One method is weighing. I will go into inverse probability of treatment weighing. I won't go into the details, but one key advantage of this method is really balancing both groups and you don't have to exclude patients. Still, we have a lot of challenges. Let's talk, for instance, about limitations in matching. Let's say you have a male, born in 1948, raised in the UK, married twice, lived in a castle, wealthy and famous. This is Prince Charles, of course, but this is also Ozzy Osbourne, and this is a match. So here you can really see what is called residual confounding. For instance, on the left you have a tie, on the right you have a cross, but of course they are very dissimilar persons. So this is really what we call unmeasured confounding variables. Another challenge is interventions work too fast. In this very elegant work from Mani Mohyuddin and Vinay Prasad, they show that when an intervention works very fast, this is implausible, this is almost impossible, and this is mainly due to selection bias. This can be seen with historical controls, but also with match analysis. And last, I will touch upon what is called systematic bias and residual confounding, and I will speak about the chronotherapy context. Francis Levy will present data, and this is a topic I'm really passionate about. But the question is always this one. Are patients who come in the morning are healthier than those unable to come at early times? And these kind of questions, or comparable ones, can really be seen in retrospective studies. Emulating trials. This is adding another layer, a very powerful layer. The target trial emulation framework, for instance, that Miguel Hernan made a lot of work on that. I think a key strength, a key advantage here is that you will have a protocol even before looking at the data. So this will prevent you what we call p-hacking or data dredging, looking at the data in several ways until you have the data that is more convenient to you. So this is, I think, a very elegant tool. Still, it's not the same as a randomized clinical trial, and that's why we have to talk about pragmatic trials. A pragmatic trial is a trial with very few exclusion criteria, which is really closer to daily practice. In this recent EORTC paper, which I also encourage you to read, they really separate the difference between explanatory trial on the left, which are usually registration trials, for instance, and pragmatic trials on the right. As you can see, patient population in pragmatic trials are diverse and representative. The delivery of intervention is per routine care. The comparator arm is more as usual care and not protocol restricted as in explanatory trial, and the outcomes measured are often survival. It's overly recognized that there is a need for pragmatic trials. This is a paper from Alexander Leary, Benjamin Bess, and Fabrice André. This really have the ability to limit the efficacy-effectiveness gap and other gaps, and this is my stance. Randomization remains the gold standard for isolating the effect of a given intervention. What is the challenge with pragmatic trials? The main challenge is really with this question. What is the real-world status of trial funding? And we know we are living in a world where most trials are industry funded and there is limited incentive for the industry to conduct such trials. So we have really to think about new models, new incentive for pragmatic trials. My conclusions: patients enrolled in trials are younger, healthier, with less comorbidity than the real world, and this creates gaps, the famous efficacy-effectiveness gap, but other gaps. Real-world evidence can quantify and benchmark those gaps, and this is really helpful to inform decision-making. This can already inform your practice in some populations that are systematically excluded from trials. Pragmatic trials can, with less stringent inclusion-exclusion criteria, answer very relevant questions, and like optimal dosing, timing, and duration, for instance. Limitation for real-world evidence, I think comparing strategies really tough and really challenging because of selection bias, and pragmatic trials are very challenging to run. I want to acknowledge two important persons for me: Professor Alfredo Adeo, which is the head of oncology unit in Geneva University Hospital, Professor Vinay Prasad, which is now the new FDA CBER director, also patients and their relatives, colleagues and friends from Geneva University Hospital, the Geneva Swiss Ethics Committee, the Centre Léon Bérard, which we are collaborating with, the SAKK, which is the Swiss Collaborative Trial Group. This is my research website, some projects, my detail. I want to make some promotion for this new ESMO Rare Cancers Journal, which I'm co-editing with my colleague, Dr. Ahmed Dufresne. And we have now the lay summary slide that you can check out. And with that, I really want to thank you for your attention. Thank you very much.